So clinical hyperandrogenism, for that you will take a history and examine for these three things that I told you: acne, hirsutism, and alopecia. For hirsutism, there are various scoring systems. So they will grade the hirsutism in various parts of the body. 8 parts of the body are taken, and score of 1 to 4 is given. And that's called the Ferryman-Galloway score. Maybe you have read of it in your MBBS days. So there is a FG score, and there is a modified FG score for hirsutism. Then there is a Ludwig score for the severity of alopecia. And there is no scoring per se for acne, but acne is quite common. So you just say that acne is present or acne is absent. Now, the second part was the oligoanovulation. Now, how would oligoanovulation present? It would generally present with some kind of abnormalities in the normal menstrual pattern. So if the normal pattern is, say, periods of around about 7 plus minus 3 days, coming at intervals of 28 plus minus 7 days, in these women, there would be oligomenorrhea. So there would be periods coming at intervals of, say, 45, 50, 60 days, like that. So they have less than 9 periods in a year. That's more common. The less common variation is secondary amenorrhea, where somebody doesn't get periods only for a period of 4, 5, 6 months. And then also there can be dysfunctional uterine bleeding, in that when you get the period, it's either really scant, or it's very, very, very heavy, because the lining has been building up for the last 4 or 5 months. And when it all sheds together, you have a very heavy kind of bleeding. For polycystic ovaries on ultrasound, like I said, the vaginal probe is the best if it is available. But of course, vaginal ultrasound is not possible in those who are not sexually active. So an abdominal ultrasound is done, but generally abdominal ultrasound does not show the antral follicles so well. So you can maybe monitor the volume of the ovary, try to measure follicles, but it's really difficult. The best way to do it is a kind of 3D measurement of the volume and all that, excluding the other extraneous things. Of course, till 8 years after menarche, one should not do ultrasound. Now, this again is something that the common folk don't know. Generalists, like general physicians and all, would advise an ultrasound to a 15-year-old girl who resumed periods maybe 3 years ago. So she's 3 years after menarche. Multicystic ovaries are very, very common in the ovary, because the ovary is just full of follicles. So it is very common, and a person who does not know this will probably diagnose multicystic as polycystic. So, and that's how there is a lot of overdiagnosis also happening, and a lot of wrong diagnosis happening at a very young age, and labeling of patients. Now, when we were in medical school, we didn't have these kind of phenotypes. It would just be PCOD with these features. Now, of course, medicine, as the knowledge expands, the categorization of many things increases. So the 3 parameters are the same: hyperandrogenism, ovulatory dysfunction, and polycystic ovaries or ovarian morphology on ultrasound. But it has been divided into 4 phenotypes. So the phenotype A is the classical one, and that is the phenotype A is the classical one. So it has all 3 features, and that's called classic PCO. Phenotype B will have hyperandrogenism and ovulatory dysfunction, where the ultrasound will be normal. So nothing, no polycystic on the ultrasound. Phenotype C will have hyperandrogenism, but no ovulatory dysfunction. So they would be hirsute, but they would be ovulating well. And phenotype D would be where there are no features of hyperandrogenism, but ovulatory dysfunction is there, and polycystic ovaries are there on ultrasound. And so, as I said, any 2 out of the 3 criteria are enough to diagnose PCO. So in all of these, even if one criteria is missing, 2 criteria exist, they will still be diagnosed as PCO. And generally the C and D are the ones which are milder, because once they're ovulating, fertility is not a problem. Once they don't have hyperandrogenism, physical appearance is not a problem. They are the milder ones, which would probably only be picked up on testing. The patient would not come to you saying that I have this problem. These are the phenotypes A and B, which would come to you with either ovulation problems or excessive hair growth. Of course, there's no need, there you can always make it a simpler classification, and that used to be the one in our times: obese PCO and lean PCO. So the obese ones are more common, because like I said, it's linked to the body fat. So they are 50 to 80% are obese, and the rest of them are lean PCO. The obese ones are the ones which have more hyperinsulinemia, more insulin resistance, and more hyperandrogenemia. So they have raised testosterone and DHEAS. The lean ones have less of these hormonal abnormalities, less hyperinsulinemia, less insulin resistance, less hyperandrogenemia, and also less of the metabolic aspects or the metabolic problems associated with PCO, which are hypertension, diabetes, and impaired glucose tolerance. The obese ones are also more at risk of endometrial hyperplasia, and endometrial hyperplasia is a kind of a precancerous situation which can progress to cancer. In fact, not too long ago, in between the lockdown, I treated a patient. She was about 24 years of old age, young girl, overweight. So BMI was around 35, so class 3 obesity. And she was having this problem that she didn't have periods over a period of time. She was already diagnosed with PCO, never taken any treatment. She didn't get periods for a while, and then she had very, very heavy bleeding. And so we did an ultrasound. Her lining was extremely, extremely thick. So despite being unmarried and everything, there was the urgent need to take a biopsy. You took a biopsy. Unfortunately, that showed endometrial carcinoma. So somebody as young as 24, so maybe she's had periods for about 10 years, but 10 years of ovulatory dysfunction and the endometrium silently growing because no ovulation was occurring, so no withdrawal bleeds were occurring, and that had progressed to endometrial carcinoma. And so, of course, she's fine now because she had the hysterectomy and everything. But so if you don't treat it in time, it can actually lead to very severe problems later on. And it is the obese ones which have more problems. And the other thing is the obese ones, because they have more of a metabolic dysfunction, they respond better to insulin sensitizers like metformin. The lean ones, because they have less dysfunction, do respond, but they take about 4 to 6 weeks to respond. So they don't respond immediately, and their LH levels are higher. We all know the problems of obesity. Other than PCO, there is a risk of high blood pressure, being hypertensive as an adult, even developing diabetes later on in life, developing high cholesterol levels. So these all problems, and I'm sure you are familiar with this classification of the normal BMI, weight by height square in meters. You hardly ever see anybody in the 18 to 24 now with the lockdown and with the sedentary lifestyles and the work from home and the study from home thing that has started. Most people who come to us are above 25 BMI, is generally above 30, usually class 1, class 2 obese. So very strict weight loss regimes are needed there. And diabetes, again, one of the things, these are all metabolic things. They are all linked together. So you have one metabolic problem that indicates that your body systems are already susceptible to developing 4 others. So that's why one has to be very careful to nip this very early in the bud. And like PCO, Polycystic Ovarian Syndrome, there is also a metabolic syndrome. Again, so this cohort of problems that occur at the metabolic level together. So with central obesity, there is hypertriglyceridemia, there is low HDL, there is hyperglycemia, and there is hypertension. And we all know what happens when the lipids go high and the blood pressure goes high. You have CADs and you have strokes, and of course, other problems. So you angina and cardiac arrest as well. So that's why it's very important to treat this kind of metabolic abnormality that begins to develop. So the consequences of not treating PCOS far out. So the risks of not treating, the benefits are more than the risks. So that's why one should treat, because the risks are so high that if you don't treat, there will be many, many problems developing gradually over time. I already told you about endometrial carcinoma, dysfunctional bleeding, obstructive sleep apnea comes with it, the territory. So all of these metabolic things, they come one by one. And of course, if somebody is married and trying for pregnancy, then infertility also rears its ugly head. So with that, I come to this is the second part of the lecture, the treatment and the implications for fertility. So what does the treatment do? The treatment that is given, it will regularize cycle, because that's our aim. We want to correct this oligoanovulatory problem. We want there to be regular withdrawal bleeds so that the lining does not grow beyond the normal. It takes care of the acne. It takes care of the facial hair growth and hirsutism in other parts of the body. controls the blood sugar. If they're married and they're trying for a baby, increases the chances of pregnancy, and in the long term also reduces the risk of developing diabetes and heart disease. So the benefits far outweigh any kind of risks the medicines may have, right? So now when we come to the management of PCO, it's the simplest things which work the best and which work in the long term. The simplest ones are lifestyle modifications, which are diet and exercise. So I'll come to what diet and exercise do and how they help. For acne, the other simple things that someone can try is washing the face regularly, avoiding any kind of skin irritants, and not picking and squeezing the pimples. For excess hair, one can go for these kind of mechanical and chemical methods of hair removal, like waxing and laser and all those kind of things. And then for PCO per se, there comes the medical management. Now, the first and foremost medical management is to lose weight. Losing weight will regularize the cycles, will improve all the blood parameters, and it will be like a win-win situation, because you have lost the blood, you have gained body image, as well as you are safe from the long-term effects of PCO. Now, the other common treatment which is given for PCO is the oral contraceptive pill. There are various types of it. There are various generations of it. For a particular kind of PCO symptom, a particular kind of pill is preferred. So OC pill in itself could be a lecture in itself, actually. The kinds of pills, what they address, how they work, all these kind of things. But now, because since today we are talking about from the fertility point of view, so just I will not go into the details of contraceptive pills, but yes, they do regularize the cycles. They reduce heavy bleeding over a period of time, treat the acne and the hirsutism, and also decrease the scalp hair fall. Then insulin sensitizing agents are very important in the treatment of PCO, because the most common biochemical problem that is occurring is a kind of insulin resistance. So insulin levels are high, but the body is not responding to that insulin. So insulin sensitizers like metformin work very well here, and they also help to, and they are kind of an add-on therapy to the OC or any other treatment that you will be starting for PCO. From the fertility point of view, there are ovulation induction drugs like clomiphene. For hirsutism specifically, there are certain anti-androgen drugs like aldactone and all spironolactone and all these which are given.